Hello, everyone. Good evening. I hope everybody can see me and hear me okay. You're all very welcome to this evening's webinar. Thank you so much for joining us on this lovely sunny May evening for what is the second installment in our GP webinar series in 2024. So in tonight's hour-long webinar, we're joined by Dr. Rachel Egan, who's a principal clinical psychologist, and Dr. Clíona Hallissey, who's a senior clinical psychologist here at St. Patrick's Mental Health Services. And Dr. Egan and Dr. Hallissey tonight will be discussing overcontrol, which is sometimes referred to as too much self-control, and the associated impacts that may have on a person's mental health. The webinar is going to focus on what costly and harmful overcontrol looks like, how it might present, and the three core areas in which it impacts people's lives. In terms of housekeeping, we just have a little bit before we get started. So ICGP CPD certificates are going to automatically be sent within the next 4 weeks to any GP who is registered and is attending live this evening. At the end of this evening's webinar or presentation, we'll have an opportunity for Q&A. So if you've got any questions as we go through the presentation, please feel free to submit them using the Q&A function, which you should see on the bottom of your screens. You can submit them as we go throughout the webinar. You don't need to wait until the end for questions, and we'll get through as many of those as we can. So we'll get started straight away. I know we've a lot to cover this evening, so I'll introduce you to tonight's speakers, Dr. Rachel Egan and Dr. Clíona Hallissey. Thank you so much, Rachel and Clíona, for joining us this evening.
So thanks very much, everyone, for attending tonight. As Sinead said, I'm Rachel, this is Clíona, and we're two of the psychologists in the psychology department in St. Patrick's Mental Health Services. So I'm just going to share my screen with you now and tell you a bit about what we're going to cover in this evening's webinar. So tonight our hope is to speak to you a little bit about what is overcontrol and what we mean by that. I suppose before we even start, it's important to mention that at this point that actually being overcontrolled is not necessarily a bad thing or anything like that. There are many wonderful qualities to it. But what we do find is that often at extreme ends of being overcontrolled, that people struggle with many mental health difficulties. So as we're going through the webinar, you might even start to think, oh, I can identify with some of that, because we do find that many of us in kind of healthcare and mental health care in particular often fall on that end of the spectrum as well. So we're going to speak a little bit about the differences between overcontrol and undercontrol. We're going to chat to you about the difficulties associated with costly and harmful overcontrol and how that might show up in your GP surgeries, or what kind of things people may present with. We're then going to talk a little bit about the treatment available here in St. Patrick's Mental Health Services, and that's a transdiagnostic structured group therapy program called Group Radical Openness. So we'll tell you a little bit about that. And as Sinead mentioned, then we'll have a bit of time at the end for questions and answers. So I suppose, what do we mean by overcontrol? I suppose that the concept of self-control has actually been around in the literature, especially the personality literature, for many years. So there was a Stanford psychologist called Walter Mischel who devised the marshmallow test back in, I think it was around the 1960s. Some of you may be familiar with this. If not, I would definitely recommend Googling it and watching some of the YouTube clips on it. It's beautiful to watch. And essentially what they did is they were looking at this idea of self-control in small children. So they brought a number of children into a room and they gave them one marshmallow, and they said, if you can wait 15 minutes, we'll give you, and not eat the one marshmallow, we'll give you a second marshmallow. So it's like I said, it's quite entertaining to watch. So some children have the marshmallow scoffed before the person has even left the room. And then you see other children who are there kind of looking at the marshmallow and smelling it and diligently waiting to get their second marshmallow after about 15 minutes. And the idea was that these children had more self-control. And I suppose that people thought, the more of this you have, the better, that it was likely to lead to better educational status, better employment opportunities, kind of general well-being overall. So for a long time, it was this idea that you should develop self-control and teach it and kind of encourage it, and that being stoic and strong and resilient was better. However, then kind of fast forward a few years, and I suppose a number of psychologists, and particularly one man called Tom Lynch, asked the question, but could there be something of like too much of a good thing? What about people who have too much self-control? Could there actually be costs to this? And as it turns out, there are, and we find that overcontrol actually underpins many mental health difficulties. particularly things around treatment-resistant depression, and certain eating difficulties, and some obsessive-compulsive personality difficulties, and things like that. And we're going to speak a bit more about that in detail after. But I guess that's one of the things then we started to look at and think about, particularly in PATS, where we were thinking about what are these cohort of people that we're seeing, and are we meeting their needs? And I suppose another thing that we found was that often people who struggle with costly and harmful overcontrol, these difficulties go unseen for many years, or they're not addressed, or I suppose they may have their first line of treatment options may be medical interventions and not necessarily psychological or therapeutic, because they tend to be the people who are functioning, in inverted commas, really, really well, because they're the doers, and you know, they're not maybe expressing emotion, and they're kind of getting on with life, and then hit a wall, and often that can be very serious. So just to think a little bit about kind of some of the differences between overcontrol and under control. And I suppose under control is often what we typically associate with people who might come to mental health services. So this table just kind of outlines some of the areas. So if we take that first one there, the kind of core problem, I suppose often people with under control would talk about really, really struggling to regulate their emotions. So they would describe life as quite chaotic, very tricky. Emotions are really big, really powerful, and very difficult to manage. Whereas with over control, what we tend to see is actually there's an over-regulation of emotion. People are kind of down-regulating emotion all the time and suppressing. And they would describe quite an intense feeling of loneliness, a feeling of almost being, a lot of the people we work with would describe things like, I feel like a bit of an empty shell, or, you know, I'm almost like on the outside of my life looking in. So that sense of not really feeling very connected to emotions or connected to others. In terms of behavioral style, those who struggle with the extreme end of under control would often be described as impulsive, or they themselves would describe feeling quite impulsive and you know, struggling again, maybe perhaps with routine at times. Whereas those on the more over control side of the end of the continuum would often describe being quite risk averse. So really not liking spontaneity or novelty, and wanting to ensure everything is sort of planned to the nth degree. And again, as you can imagine, that in its extreme can be quite costly in terms of missed opportunities, and maybe not engaging in life in the way they would want. In terms of societal response, I think this one's often quite interesting in that, sadly, I think those who struggle with extreme under control often attract disapproval, and that sense of, oh my, you know, you need to regulate your emotions, you need to do X, Y, and Z. Whereas with over control, it tends to attract reward. And this is the person at the funeral who will make sure everybody's okay, and make sure everything's organized, and check in on everyone else. And so they tend to be described as, again, those words like stoic and strong, and you know, you never know what's going on. They always show up. So it's often rewarded. And again, if we think of small children, they're the kid in the class who's diligently doing their homework, but nobody maybe checks to see how are they okay, because they don't create any problems. In terms of thinking styles, with under control, we tend to see perhaps a bit more of underthinking and over emoting, whereas with over control, there's a lot of overthinking, often kind of a lot of difficult rumination, and sort of maybe pervasive fixation on things, and tend to under emote. And then in terms of relationships and interpersonal style, I suppose with under control in general, they would describe kind of really craving intimacy and connections, and having quite an intense fear of abandonment, which can lead to difficulties in relationships. Whereas with over control, so again, people that we would work with would talk about really fearing intimacy, really struggling to trust others and to feel safe, and often coping by abandoning. So that idea of, actually, I'll abandon the relationship first before I get hurt. So that sense of always being, again, a little bit more distant. So to slightly confuse matters, but while there are distinct differences that I just mentioned there, it is important to note that there are also some similarities. especially at the extreme end. So again, I just want to revert to saying that there are many qualities of both over and under control that are really amazing and wonderful in life, and we all tend to fall somewhere along the continuum. But at either extreme end is where we tend to see quite significant mental health costs. And the thing with the similarities, I guess at times what we have seen is that people say, well, is that over control? Is that under control? It might be a bit difficult to formulate or to see exactly what is presenting. And what we find is that often the function of the behaviour or how it manifests is quite different between under and over control. So in terms of what those things are, excuse me, in terms of some of those similarities that may show up in both presentations, but are actually functioning differently. Self-harm is the first one. So self-harm has tended to be quite indicative of under control and is often sort of immediately termed that, and someone may be sent to a particular treatment option like DBT therapy or something like that. However, we do find that many of our over-controlled people that we work with also self-harm. The difference and is that it's often conducted in private. It's usually quite carefully planned. It may not require medical attention. So, for example, we've worked with people who would cut, in particular places in their bodies, perhaps like under their arm or their inner thigh where nobody might see it. They might have the medical like bandages and sutures and things ready, and they tend to do it alone, or we've often seen people who may injure themselves in other ways, like perhaps hurting themselves, punching themselves, but again having it in places in their bodies where the marks wouldn't be seen. So we find that it's actually really important in our assessments to kind of really probe how this shows up in terms of looking at, is this more an under control coping or an over control coping? And the second area then is around displays of emotion. So again, that idea of like a lot of emotion tends to be seen as more indicative of under control. However, many of our over control folk do display emotion, often after a period of suppressing it for quite some time, or it may seem a little bit uncharacteristic to what's just gone on or almost disproportionate, but it does happen, and we call this emotional overflow. But again, it's usually in private or only in front of loved ones. And often we see that people describe feeling quite ashamed after expressing a lot of emotion, which may then feed into the cycle of suppressing it again for quite some time. Another thing I think that is quite important to mention, particularly when we're assessing for this or when you're thinking about this with some of your own clients, is that many of our over control folk would over-report emotions. So they might say, oh no, I get angry, I get really sad, and then when you probe it, it's like they've shed a few tears 6 months ago, or they had one little bout of frustration a year ago, and it's like, oh no, actually that's not necessarily the constant ebb and flow of emotion. So important really to kind of probe and explore that. And loneliness is another. So again, both over and under control would describe feeling lonely in different ways. So many of our people who are over control, like I mentioned a bit earlier, would often talk about that feeling of being a bit like an empty shell, or not really understanding others at times, or they may have a large social network of what appears to be on the outside, but nobody would really know what's going on for them. And we would find that sometimes many of their friends or family might not even know they're in hospital or they're attending our therapy. And again, in terms of exploring this with our clients, sometimes they say, oh, no, again, I have a great network of people around me, and we might follow up with, oh, and would they know that you're attending St. Patrick's Mental Health Services? And like, oh God, no, why would I want to do that? I wouldn't burden them or worry them. So that sense of actually being quite alone in their struggles. And the leakage and overflow, which I mentioned earlier, is that idea of kind of sometimes an outburst of emotion that can shock people at times, can seem very disproportionate. We tend to use the word overflow. Leakage is what is used in the literature, but many of our clients have told us that they actually don't like the word leakage. So overflow, I think, captures it a bit better. And then finally, interpersonal difficulties. So again, that tends to generally be associated with under control, but actually many people who are over controlled have interpersonal difficulties that show up a bit differently. So in work, it might be because they're quite rigid and rule governed and they want things done right. So kind of maybe struggle to see others' perspectives at times, or, you know, that sense of, well, I'll just do it because it won't be done right. And of course, as well, that kind of lack of deeper, authentic social connections can lead to difficulties. So friends or family might say, yeah, like we're connected, but again, I'm not really, just never sure what's going on with the person. So there's some of the things I suppose that we would often see show up on both ends of the continuum, but as I mentioned, they're important to really probe around what is the function behind them, and how are they showing up. So just to kind of finish on that little bit, I suppose one way I've heard it described that we feel is a nice way to capture it is this elephant and rider analogy. So in under control, the elephant is emotion and the rider is reason. So everything's fine if the two are going along the same path, but if the elephant decides to take off in another direction, there's very little the rider can do to sway him otherwise. Whereas in over control, the elephant actually represents reason and the rider represents emotion. So there's not much room for emotions. And as we know, as human beings, we're all born biologically ready to experience and express emotion, and they're what make life beautiful and colourful and help us connect and feel part of. So if we have a life where reason is the most prominent and emotion is very much in the background, it creates a lot of difficulties. So I am now going to hand you over to Clíona.
Thanks, Rachel. So yeah, I'm going to talk a little bit about, first of all, about the difficulties associated with costly and harmful over control. And I suppose keeping in mind these might be some of the presentations that you might be seeing in your GP surgeries. And to do this, I thought it might be helpful to use, I suppose, a few kind of examples of people that myself and Rachel have worked with. I'm giving them pseudonyms just to protect their confidentiality. But hopefully it can give a bit of a sense of the kind of presentations that we might be seeing. So the first one there, avoidant and obsessive personality difficulties. So Charlie had a diagnosis of obsessive-compulsive disorder. He was obsessed with productivity, and he was constantly thinking that he had to do everything kind of in an orderly way, found himself questioning and analyze everything he was doing. He experienced a lot of intrusive thoughts, constantly thinking to himself, am I maximizing my time? I think earlier on in his life, in his teenage years, he had a fear of contamination, but this had kind of changed over time, and now it was really about productivity. He engaged in rituals around eating, and he also had kind of lucky numbers, so that obsession was kind of there in a lot of different areas of his life. I suppose these high and unrelenting standards led Charlie to be very critical of himself. He was constantly feeling like he wasn't doing enough or wasn't good enough. This level of internalizing and obsession left little room or time for connection. And I suppose it wasn't something he could prioritize in his life or felt he could when he needed to be constantly working and keeping up his standards and doing everything perfectly. He described himself as closed off to new relationships, and he spoke of feeling incredibly lonely. He had a tricky relationship with his parents who fought a lot, and Charlie didn't want to burden them further. So I suppose that led to more and more internalization. And that included internalizing his emotions as well. He worked hard to suppress these as he worried about burdening others. So if we go on to the second one then, treatment-resistant depression. Aaron had a diagnosis of dysthymia. He'd been experiencing low mood for as long as he could remember. It kind of, when he spoke, it felt like it had been like that for his whole life. And in the past, that had led him to thoughts of suicide, and he'd made some suicide attempts as well. He spoke of being very withdrawn. He was spending most of the day playing video games and watching TV, and he had very little spontaneity in his life. Everything was kind of the same every day. He described feeling stuck, and he was very isolated and lonely. He had very few connections. He spoke of suppressing his emotions to the point that it was difficult to know what he was feeling or what was going on for him, and he often felt numb. In group, he shared that he'd gotten a lot of messages growing up that emotions weren't welcome or okay. The third one there, eating difficulties. So someone we worked with, Maria, had a diagnosis of an eating disorder. She engaged in restriction of food and purging after eating. She had a lot of shame about this, so really struggled to talk about it. She felt very emotionally distant from her family and had some trauma experiences in her teenage and young adult years. She spoke about the control that the eating difficulties gave her, and she had a huge fear of losing control through binging on foods that she felt were bad. Different harmful coping strategies became a habit for Maria. She used to speak about everything being kind of a habit and feeling really stuck in them. For example, she would cut herself, so self-harm through cutting. She spoke about suppressing emotions to the point that they would overflow, which sometimes led then to cutting or purging. She had a huge amount of shame and was very self-critical. She tended to keep others at a distance for fear that they would find out these things about her, which she didn't want to share. And again, similar across all these cases, she felt very lonely and isolated. The fourth one there, addiction difficulties. Tracy had a diagnosis of alcohol dependence. She spoke about always feeling like an outsider, not fitting in. That was in her family, in her friendship groups, in school, throughout her life. And she kind of reflected that alcohol was a way for her to loosen up, maybe kind of suppress that feeling of being an outsider, maybe feeling part of a little bit more. She spoke again of keeping other people at a distance, not letting them get to know the real her, and wearing a mask. That was a big theme for Tracy. She spoke of a fear of uncertainty, trying always to plan and be prepared and do the right thing. She took on a role of carer. She was a carer within her family, and kind of a lot of responsibility was placed on her. She often had to put other people's needs ahead of her own. But she also worked in a caring role in her workplace. She took on a lot and worked really hard and had really high standards for herself to the point of burnout and not being able to work anymore. And that was kind of one of the things that contributed to her admission and her kind of mental health crisis. She had experienced a lot of loss in life and internalized all of this. She felt a lot of shame about her addiction and had an urge to make things right, prove herself to others, but this meant that she didn't get much support or have her own needs met. So she was always trying to do everything right, look after other people, prove she was good, but then that meant she got no support herself. Anger was her go-to emotion, but she buried lots of sadness and fear, and alcohol became a coping strategy to deal with them. And then the last one then, certain forensic presentations. Jamie was someone we worked with who had a diagnosis of adjustment disorder, a few different diagnoses, adjustment disorder, dependence syndrome, and ADHD. He was arrested for driving under the influence after crashing a car whilst he was driving with his friends in it. Jamie had a difficult time growing up. He didn't have a relationship with his biological father. He'd experienced some traumas as a teenager and he struggled to pay attention in school and kind of had a sense of himself that he wasn't good at things or wasn't able to do things. He spoke of feeling lonely and empty, wearing a mask, and trying always to adapt to who he thought people wanted him to be. He tended to overanalyze things and had really high standards for himself, which he never felt he could reach. He spoke of having intense emotions, but working hard to suppress these. Anger was his go-to emotion, but he struggled to experience sadness. He reflected that he used substances to fit in with others, and underneath all that, he felt very wrong, that he was a problem, that he was bad in some way. So they're just a flavour of some of the people that we've worked with and maybe some of the kind of difficulties they might present with. Were kind of underneath those, there was some costly and harmful over control. Thanks, Rachel. So I suppose what you might be kind of hearing there is that everyone we've worked with has a life story, and everyone I'm sure you meet in your GP surgery has their own life story as well. And over control is a coping strategy and can develop as a coping strategy. It can come and develop from a need to cope with difficult experiences in life, for example, trauma, abuse, or maybe the person has never really had their emotional needs met. They might have been kind of emotionally neglected in early life or in their adult life. And I suppose when we think of people's family systems, it can come out of kind of two different places. Sometimes it can be a way of trying to fit in and integrate into an over-controlled family system. So we meet a lot of people who might have got messages that they need to just keep calm and carry on, to do things really well or to do things perfectly. Maybe work or academia was kind of emphasized in the household. And maybe it was spoken about that just emotions were not a good thing. You shouldn't get emotional. You should keep a lid on things. And they might have received a lot of reward for doing that, for times that they were able to just get on with something, even if it was really difficult, and not cause any hassle or not cause any fuss. On the other side of it, some of the people we meet and some of the some over control can happen within the context of an under controlled family system. So maybe somebody grew up in a family system where things were a bit more chaotic, where there might have been a lot of expressed emotion. So maybe there was their parents or siblings or different people in the home who had big emotions and were expressing it a lot. And maybe that was in kind of harmful ways, maybe being kind of overwhelmed or being a bit aggressive at times. So, a child who's growing up in that environment might learn emotions are a bad thing and lead to harm or lead to aggression or lead to kind of really bad behaviors. Or they might have just learned that it's really good if I can keep a lid on things and hold it all together. That might become their role. They might have been the kind of parentified child, given a lot of responsibility to look after everyone or hold it all together as a young age. So I suppose it can happen from both sides, maybe trying to integrate into an over-controlled family system, or alternatively, maybe trying to balance or survive within a chaotic or under-controlled family system. So I'm going to talk a little bit about what we see as the three core themes of over-control. Over-control obviously kind of covers an awful lot, but these are the three areas that we talk about a lot within our program and are kind of a good way to, I suppose, be able to explore this or start to explore this. So if you go to the first one, Rachel, thank you. So the first theme we talk about, or area of over-control we kind of explore, is distance in relationships. So people who are over-controlled might find themselves keeping other people at a distance. They might not want to reveal personal information about themselves to others. This can be for lots of different reasons. It can be maybe not feeling safe, fearing judgment or rejection or abandonment. They might have learned kind of those messages growing up that things should be private, that you don't share information with other people, to keep things in the home. That's something we kind of often hear. I suppose there might be some sense of being skilled at wearing a mask, and avoiding and not giving away too much. They may have a strong desire for connection, and most of us do. I suppose we know that's part of the human condition, that we want to connect with others. But they might also fear it and distance themselves as a way of staying safe. They might be conflict avoidant and avoid feeling vulnerable. And I suppose conflict can often come from emotions such as anger, and that might be something that some people aren't really that comfortable with or can connect to within themselves. And I suppose when we get close to people, generally speaking, we're going to be a bit more vulnerable, and that could be something that for some people doesn't feel safe or something that they fear. The next part then, unacceptable outsider and secret pride. So to explain a little bit more about these, they're kind of concepts we talk about a good bit in our program, which is, I suppose, ways or strategies or kind of styles we might talk to ourselves in, that actually end up leaving us on the outside of things or feeling distant from other people. So the unacceptable outsider, first of all, might be a type of self-talk we might have about kind of highlighting all the ways we are different to other people, how we're not good enough. Maybe I don't fit in because I'm not smart enough, I'm not funny enough, I'm too quiet, I'm too shy, I'm too odd. These are all the reasons why other people wouldn't want to get to know me. I'm not deserving of being part of the group. On the other side, sometimes we might have more secret pride. So we might speak to ourselves in a way where we might kind of remind ourselves or say things like, I don't really need them anyway. I'm better off on my own. Maybe they're not that interesting. Maybe we don't even have things in common. And actually, I'm probably better as a lone wolf. I'll just continue on as I am. And what we often find is that that secret pride comes from a place of probably trying to protect ourselves from that unacceptable outsider. It's really hard to feel undeserving or like that we don't fit in. So it's often a way that people might develop of actually just having that kind of secret pride there in the background of actually I don't need other people. I'm better off on my own. Actually they're not the kind of person I want to get to know. So another area, or the last area in this distance in relationships, is holding on to grudges and past hurts. And this is often something we see is maybe there's been ruptures in relationships, maybe there's been fallouts or conflict. And for somebody who's over-controlled, it might be very hard to get past that, to repair things. They might end up holding on to grudges, reminded of things that haven't gone well, but struggling to express that and then kind of holding on to the past hurt. So I suppose the cost of all of that is that we often, and you might have heard it in the kind of scenarios of the people cases I discussed earlier, that people are often left feeling lonely when they've gone through something difficult, then when they've gone through a crisis in some way, especially a mental health crisis, they might struggle to share that with other people in their lives. If they've been keeping people at a distance, if they don't want to be vulnerable, it's going to be hard to open up about it. So they're going to struggle to let people in. They might fear judgment, rejection, abandonment, like I said earlier. And therefore, they're not going to get their needs met. They're not going to get that co-regulation, as Rachel's going to talk about in a little while, that is really important to all of us. So that's really difficult, and that's often what kind of leads people into our program a little bit. So then rigidity. So part of over-control is liking to have control. You know, for all of us, we'll all want some level of control in our lives, but for some people this becomes quite extreme and quite costly. So there might be a strong desire for structure, control, and rules, and for kind of environments or scenarios that have them. And then if there's environments or scenarios that don't have them, maybe it's kind of environments which are a bit more playful or a bit less structured, or more about kind of fun or, you know, socializing. That can be kind of hard for somebody if they find those, if they don't have the structure that they're used to. The rigidity might also be about avoiding uncertainty and not liking that ambiguity that can happen, especially that happens a lot in relationships with other people. There can be perfectionism, being high achieving, having that strong work ethic. And I suppose on the other side of things, that can also lead to procrastination. So we see a lot with people who do our program who have that over control in their lives, that they might be working really, really hard. That can in itself lead to burnout at times and just kind of overwhelm. But on the other side of things, if we're always trying to do things perfectly, it can actually be really hard to start a task. People can feel like a failure even before they begin, which can lead them to procrastinate it to the point of kind of that can cause difficulties in their lives as well, maybe in their workplace or in their relationships. They might have rules about how they and others should behave. And I suppose this can cause then issues within relationships in their lives, but maybe for the person themselves, maybe they're being very self-critical if they're not able to meet those rules or standards. Someone might dislike novelty, spontaneity, or fun, and then lose out on opportunities in their life. Playing fun might need to be earned. So needing to kind of work really hard in order to be able to get something they like or enjoy. And it might feel like there's no value in it unless it's productive. They may have difficulty taking on other people's perspectives. They might be harshly critical of self, and this might extend to others, like I was mentioning before, and maybe punishing themselves for not meeting those standards. And I suppose when we think again about the cost, I've mentioned them a little bit there, but there might be a struggle to adapt, especially if situations change. That can lead to somebody going through a mental health crisis. If they need to have that structure, if they need to have that certainty, life mightn't always give us that. And that can kind of often lead to something like a crisis. I suppose we sometimes see people after going through something in their workplace. Maybe they were criticized in their work. Maybe they made a mistake. Maybe they experienced some sort of conflict in work. Maybe they were working so hard, they just burnt out. But kind of workplace events and crises can often kind of lead to a mental health crisis for somebody when they're quite over-controlled. And I suppose when we're thinking about relationships, for somebody who's quite rigid, they might really impact their relationships, their ability to have fun with friends or family or partners. And that can lead to kind of conflict as well in their lives, which might eventually contribute to their mental health difficulties. If we go on to the next one there, Rachel. Thank you. So the last theme then, kind of within overcontrol, is inhibited emotion. So I suppose there's two parts of this. Somebody might inhibit the experience of emotion, so they might really try to avoid ever feeling things. And that's quite hard to do as a human. So they might find themselves avoiding situations that bring up emotion, avoiding events, or avoiding people that might bring up emotion. If we think about avoiding people that might bring up emotion, that might be avoiding actually developing deep and meaningful relationships, whether it's romantic relationships or friendships or whatever it is in their life. And the other part of it is that someone might be inhibiting the expression of emotion. So it might be that they're feeling a lot. Rachel mentioned this a little bit earlier, but they might find that they need to mask it, saying, I'm fine, everything's grand, when actually they're suffering a lot internally. Some might feel emotions intensely and work really hard to suppress and numb them, but others might not feel anything, or might kind of talk about how they feel a constant state of kind of numbness and feel quite stuck in that, which is a horrible experience to feel numb for long periods of time, because again, feeling emotions and the kind of myriad and spectrum of emotions is part of being human. And I suppose we often talk in group about how it's very hard to suppress and avoid or not feel the difficult emotions, maybe sadness, anger, shame, whatever it is, without also not feeling then the good emotions like joy or love. So you can't really have the good stuff without the difficult stuff. And often when people are attending our program, maybe they've suppressed to the point that they're not feeling either, which is really hard. They might have strong rules or beliefs about emotion. And again, these might have been things they learned in their household, in their family system, maybe in their community or cultural system as well. They might have those kind of rules like anger is dangerous, sadness is weak, expressing joy is showing off. Emotions could manifest physically. So this is a really common one and might be one that you might really see in the GP surgery, which is maybe somebody who's kind of feeling a lot of tension. That can contribute to things like migraines, kind of muscular problems, maybe gastrointestinal problems. So they might have awareness or not have awareness that there's times in their life that they're kind of going through stress or difficult times, and that comes out in their body and in their physical health more than necessary in their emotions if they're really disconnected or actively suppressing them. And then the other side, Rachel would have mentioned this earlier as well, they might experience emotional overflow at times. So if you're suppressing and inhibiting, things will kind of build up over time and it can lead to overflow. And that can be really harmful. So again, this could be somebody who, everyone thought was absolutely fine, and suddenly they've kind of had a big crisis. Maybe they've had a big outburst, or maybe they've kind of harmed themselves in some way. So this can be kind of quite extreme or can come out of nowhere, but actually it's been building up in the background for a long time, even if everyone around the person isn't aware. And I suppose the cost of this really relates to that relationships, distance and relationships theme. That kind of the cost of the inhibited emotion really is in our connections. If we don't know how we feel or we're suppressing it, other people can't really know either and won't be able to offer support or love or care, and maybe won't be able to really get to know us, because I suppose our emotions are part of who we are. And that idea of things building up over time can lead to that overflow or crisis, and possibly the person then doing something that could be harmful, using a coping strategy that's harmful to themselves or someone else. So I suppose there's a lot of cost to this theme as well. So I'm going to hand it back over to Rachel for this next piece.
Thanks, Clíona. So I'm just going to spend a couple of moments speaking to you about the treatment that we have available in St. Patrick's Mental Health Services. And I suppose I was just struck as Clíona was going through that. I think that idea that we know that, emotional loneliness and loneliness in relationships is one of the biggest predictors of mental health difficulties. And like Clíona said, a lot of people we see have gotten to a point in their lives where they've, perhaps made like a really serious suicide attempt or really serious kind of methods of harming themselves that often others did not see coming. And they don't have that kind of support or network around them to help them through it. So just to tell you a little bit about our program, I suppose our journey started initially with using the skills-only approach of, excuse me, radically open dialectical behavior therapy. So some of you may be familiar with that. That's the therapy that was developed by Tom Lynch, who initially kind of coined this term of overcontrol and really started to look at this area. Excuse me, but when we started with the skills only group, I suppose we found it just wasn't meeting the needs of our clients in the way that we felt was most helpful. So we've actually gone on to develop our own treatment intervention called group radical openness. And I suppose like that, important to mention, it's quite distinctly different from RODBT in that it is a group therapy. So it's not a skills class. It's actually where people start the group together and do the work in the group. So it's structured in that we cover those three themes that Clíona was speaking about over the kind of 5-month period. Excuse me again, sorry. But like that, all the work happens within the group. So it's transdiagnostic. So anyone who comes to our group, may have a number of the difficulties that we mentioned earlier. So we don't focus on symptoms or diagnoses. The target is working on the overcontrol. The group occurs for 27 sessions over a 5-month period. So we have twice weekly sessions for about 12 weeks. And then the final 3 weeks are just once weekly to taper the ending and give time to work on and explore the ending. Sorry, I'm just going to take some water. This always happens to me when I'm presenting. It's like an unconscious thing where I'm nervous. So yeah, so it happens over the 5-month period. And as I mentioned, the focus is on those 3 core themes that Clíona was speaking to you about. I suppose the first half of the program up to kind of session 15, it is really about developing an understanding and awareness of their overcontrol, really importantly, honoring and validating why they struggle in the way that they do. So again, the message being, it isn't that there's something wrong with you, this makes sense, but let's look at the parts that are really hurting you and how we can work on that. Learning is experiential, we put there, so it's not a case where they'll come and learn a skill and head off. We actually feel that the best way to learn about connecting, emoting, being more flexible is with trusted others. And in that, I guess, safety is the key really in terms of the therapy. So we spend a lot of time focusing on building common humanity within the group and that idea of the antidote to the loneliness. So we will always, I always get comments of like, oh, it's not just me, and oh my God, I can't believe you go through this as well. I always thought there was something wrong with me. Again, by virtue of the fact that they generally don't tend to tell people what's going on for them, to have a space where you're hearing 10 or 11 other people describing similar experiences, it can be profoundly healing. So after that midway point, we'll have a therapeutic break where we would meet them for an individual reflection session. And that's really just to kind of check in where things are going and kind of have a sense of moving into the latter phase of the program, which is more focused on even deeper kind of experiential exercises together and working on softening the parts of their overcontrol. Again, we don't talk about like, fixing it or problem solving it away or making it go away, because there's many parts that will have protected them and kept them safe for really valid reasons. So, for example, if I've learned that, that others are harmful and are going to harm me, I'm not just going to immediately go, oh yeah, that's fine, I can trust people, I'm going to develop lots of deep and meaningful relationships. It's actually going to be quite terrifying. So we spend a lot of time looking at that, looking at the fears, looking at what's going on for them, and having them experience those connections together in the room, which, like I say, is kind of really profound from what we've witnessed. So the group is the primary agent of change, less so even than ourselves. So we facilitate it and we guide it, but the idea is that over the 5 months they work together as a group, working on their struggles and sort of cheerleading each other in their triumphs and being with each other in their sadness and their difficulties. So just tell you a little bit about research that we've done on our group radical openness program. So In 2021, we published a feasibility study because it was quite a new, it is new program. We wanted to, really look at, is it an acceptable and suitable intervention for those who are over-controlled? So we gave some quantitative measures at pre-group, post-group, and 6 months after group. And we also interviewed participants regarding their experience of Tend and Grow within a month of finishing the program. So the results of this feasibility study showed a decrease in over-control traits, which was wonderful to see because it's actually a trait measure that we use. So often you wouldn't think a trait measure might necessarily decrease that much, but we constantly get kind of significant decreases in that with sort of moderate to large effect sizes, which is great. And people also had an increase in general psychological well-being. And one of the great things about this is these gains are maintained at the 6-month follow-up period. And in the interviews, participants really talked about the importance of connecting with other group members and that sense of feeling at home, finding my tribe, belonging was a word that came up a lot as well. And they also reported positive shifts in kind of self-confidence and agency and general well-being. So things that might not necessarily be directly targeted by the program, but obviously are a lovely sort of byproduct of connecting, emoting, and being more flexible in the room. After that, actually, and I don't have it in this slide, but it is in your reference section, we wrote a book on how to set up and run a GROW program. It's designed for clinicians and people who've attended our GROW trainings, but that was published by Routledge just last year in 2023. So there's also kind of like a clinician's manual on the GROW program in itself. And then just earlier this year, we published a qualitative study looking at participants' attributions of change. So I think in recent Medical Research Council guidelines are like the quantitative measures are great and you have a manual on how to do it, but like what are the participants actually saying matters? So we felt it was really important to kind of hear their words in this. So we completed a number of interviews with people after they engaged in GROW. And there were kind of 3 core themes that came out, which fit very much with the earlier research too. But the first main theme was around safety and connection. And this was a key attribution of change for people. They felt that idea of being safe, connected, belonging, understood, meant that they could then go to make the changes in their lives, which is wonderful to hear. A second core theme was about understanding over-control, which can make sense. I guess there was that sense of I really did not know what was wrong with me. I thought it was that what Clíona spoke about earlier, that unacceptable outsider and secret pride, that sense of really internalizing that I was wrong, I was bad, or there's something inherently defunct about me and I just had to keep it to myself. So hearing others and sharing their stories and understanding the concept of over-control and why it made sense in their life also promoted change and healing. And then finally, that idea of kind of carry and grow forward, which was lovely to see, and that idea of internalizing the experience of the group. So internalizing the connection, being able to draw on that, which is often used in a lot of grief work about I can still hold on to the experience, even though the actual end has happened in terms of them not meeting in the same way in the group each week. But actually I can remember what it felt like to be part of something. And I can summon that when I need to, when I'm struggling. And people use things like, oftentimes if I'm having a bad time, I think, yeah, what would the group say? And actually, how might they respond to me in this? And that sort of tended to help continue the work they're doing after the group ended. So we also have our annual outcomes report each year, which can be found in our website. And that results of that show that GROW consistently is an effective, supportive and suitable intervention for those who are over-control. So we're very pleased about that. So yeah, I'm just going to finish off with a couple, speaking of the importance of people's voices, but I'm just going to finish off with a couple of quotes from recent group members actually over the last number of cycles, but I suppose these would be very typical of what we would see. So one person said, so GROW has changed my life forever. For the first time, I was able to trust a group of strangers with my story. And I knew instinctively, excuse me, that they would not judge me. This was profound and life-altering. I now feel there are more people like me in the world. I can meet nice people like our tribe in the future, and perhaps build strong friendships. Also, I'm now fully aware of how serious my over-control was. and what it feels like to feel. So now I can continue to build on this going forward. I guess I want to feel the bad feelings so that I can feel the good ones. I also want to be able to express my feelings as they arise, rather than shutting them down and swallowing them whole. This is a journey, and there have been ups and downs, but it was totally worth it. And then just a couple more. So for me, Grow has been a real opportunity to get to know myself and my emotions, and to better understand myself and my relationships. I got a whole new sense of self from doing the program. I got the gift of awareness, and now I get to decide what to do with it. I had withdrawn a lot before this and hadn't even realized the extent of it. My overcontrol has helped me in a lot of ways, but Grow helped me to see that it had become a double-edged sword, and the group helped me to change the parts that were holding me back. And finally, another person said, Grow is the best program that I've ever done in PATS. I'm so privileged to have been given a place in the group and to have been supported by everybody. I was able to feel safe for the first time in a long time. It has been life-changing. So just 4 different kind of people's, and we get feedback all the time, sort of in general and formally, from everybody who goes through our programs. So I'm sure you might be wondering, so how do people get onto Grow, or what is the referral pathway? So just like many of our day programs, not all, but many, but for Grow specifically, somebody to attend our program, they must be under the care of a consultant-led multidisciplinary team in St. Patrick's Mental Health Services. And the referral comes from the team psychologist to us in the Grow team. And we would then conduct a detailed clinical assessment. So there's quite a nice process in that we really want to ensure that the group is the best fit for the person's needs. So we would do a more detailed assessment, ensuring that we are meeting their needs. So I'm conscious of time. So there's the references, which you'll have in your slides, or when the slides are sent on to you, if you want to read up a little bit more about Overcontrol and Grow. And just finally to say thank you very much for your time.
Thank you so much, Clíona and Rachel. Again, I'm always just so impressed by how well everybody sticks to time on these webinars, considering just how much there is to get through. If anybody does have any questions there, we have about 5 minutes to go through as many as we can. I just wanted to touch on something you'd mentioned, the book, Rachel, that was published in 2023, and how it's a guide for clinicians on how they might implement Grow in their own practice. Is that, I suppose, for the purpose of our GP audience, is that something that can be implemented in a GP practice? Is it in a mental health setting specifically? Maybe does it require multidisciplinary team input? It's probably all covered in the book, really.
And actually, I suppose I would say, like, if you're anyway in for the GPs, if you're anyway interested in finding out more, it's very readable. It's not difficult, and it really describes the program. There's lots of case studies and stuff. I think in terms of in terms of setting up an actual Grow group, it would need to be with with a team of clinicians, and we do provide trainings and stuff on that. So reading the book alone wouldn't be enough to start that, but it would certainly help inform the thinking around, oh yeah, I wonder if this is an area I'd be keen on.
Yeah, I think just based on the outcomes that you're seeing so early on, it sounds really incredible, like a really incredible group for people to be a part of. So I think the group, or the book as well, and that ability to share information among clinicians is really powerful. And those particularly the testimonials at the end, just extremely powerful testament to I suppose the work of the group. We have a couple of questions coming in there, so I'll just throw them out to the floor. So Clíona and Rachel, you can just jump in as you need or as you see fit. So are there mental health diagnoses that interventions such as growth might not be suitable for? Are there any instances in which, obviously it depends on the clinical assessment that you do, but off the bat, would there be any kind of specific things where or specific diagnoses where it's just not appropriate?
I suppose it'd be more under control, wouldn't it, Clíona?
Okay.
Yeah, sorry, I'll let you answer.
Yeah, I think we look less at the diagnosis and more at if there's overcontrol underpinning it or a part of it. So I think when the people we were thinking that wouldn't be suitable for the group would be more under controlled, a bit like what Rachel was talking about earlier. So sometimes I guess maybe people with like an EUPD diagnosis might tend to be more under controlled. But actually not everyone who ends up with that diagnosis is under control. So we wouldn't necessarily see that diagnosis and say they can't do group. We would still do a screening with them to see if they kind of meet those themes. So if they're kind of seeing in themselves, I tend to keep people at a distance, I really suppress my emotions an awful lot, and I'm quite rigid, then we would be thinking they'd be suitable for the group.
Okay, and we have a question in there as well, and it touches really a lot there on what you're saying, Clíona, is how would a GP know if a patient might need to access support for overcontrol? So what are some of the really typical signs, I suppose, that they might see in their own surgeries?
And I think that's, very much kind of what Clíona was describing earlier, those typical presentations. And I suppose one of the things we would always say is it's always good to kind of ask, because people with overcontrol might come and say, oh, I'm depressed, or I'm really struggling, and maybe give, maybe not giving a lot of information or detail, because there's quite a lot of shame around it. So really exploring like that, their connections with others, who knows in their life that they're struggling, and how are they with emotion? Do they experience and express emotion? The normal kind of ebb and flow of emotions in life. And maybe checking around that rigidity, that overworking, maybe difficulties with like really harsh standards, any kind of self-punishing behavior. Like we would see sometimes people would describe not allowing themselves to eat until they've earned it, things like that, you might not initially pick up on, but actually are all part of being quite rigid and over-controlled.
And I think now as well, especially on social media, I don't know if you see this in practice, but there's a lot of narrative about this kind of hustle culture as well. And I don't know if people are over controlled, it probably has a really strong impact on that as well.
And I think as well, often the over control person in the GP surgery might come in with a problem, but might be quick to say, I'm fine, actually, no, it's fine, don't worry about me, it's okay. So there might be the people who kind of would be quick to kind of be like, everything's fine, just get on with it. I need to get back to work straight away, that kind of thing.
So they might benefit really from further probing into that. And
definitely. And it might even be that a family member has gotten to a point where they've said, you have to go to the GP. I'm not putting up with it. Where again, they're thinking, actually, I'm fine. Just, give me a script for something and let me get back to work. But so it does require.
And I think it's a very easy thing to say is, oh no, I'm fine, actually, don't worry about me. So it can kind of then fester. We have a question there then as well in relation to group radical openness and its suitability for people with ADHD or neurodevelopmental difficulties.
We always get asked that question.
How do you?
So again, GROW is a treatment for overcontrol. So it's not a treatment for specific diagnosis, as we were saying. But we often have people who have neurodivergent difficulties. So we will have people with diagnosis of neurodivergence, and we would adapt and work with them and make sure we're meeting their needs. But like that, the treatment isn't about we're targeting ASD or ADHD or eating difficulties, or the treatment is about targeting the overcontrol. So so that's where I suppose when we were talking about our detailed clinical assessment, we would ensure not only is the person over control, but is this group the right intervention for them at this time, or is something else needed perhaps beforehand, or
and is it something they would like to work on? I suppose you might get a referral in, but somebody might meet all those criteria, but might say, actually, I don't see this cost me at all, and I don't want to work on this. Which is totally fine, but they wouldn't then benefit from groups. So we're definitely looking at their motivation to want to work on it.
Great. I can see it's just gone past 8 and I'm conscious everybody's busy and conscious of everyone's time. So I'm just going to give it another second to see if any more questions come in. But in the meantime, obviously, Rachel, you mentioned the book. Our own website, stpatricks.ie, has some information as well on the group Radical Openness program. I don't know, obviously, the PowerPoints that we will send out to everybody include some references. I don't know if there's any other resources off the top of your head that you'd signpost at this point, or direct
the website. We did do a family webinar as well. That's on the website too.
Actually, we'll share the link to that as well when we're sending out. So we'll send all attendees an email after this webinar with a link to the slides, and we can include a link to that webinar as well as part of the family series, which might be helpful even for GPs in their practice to direct family members to, or patients themselves. Lovely. Okay, I don't see any more questions coming in there, so I'll close it up there. Thank you so much, Clíona and Rachel, for your time, and thanks everyone attending this evening as well for your time. When we log off, you will see a short survey, a link to a short survey, and we'd really appreciate it if you could just take 2 minutes, give us your feedback, let us know your thoughts. It helps inform future events. We've been running this webinar series, I think now for 4 years, potentially 5. So we're always looking for feedback on new topics, feedback on things that are really helpful for you as GPs in your day-to-day practice. And then finally, which I mentioned at the start, the ICGP certificates for everybody attending this evening will be automatically sent in the next 4 weeks. So just to allow time for receipt of those. And of course, you can always get in touch with us at communications@stpatricks.ie if you've any other questions. We've comments in there as well coming in to say thank you to Clíona and Rachel. So that is it. We are back on the 14th of June or the I think it's the 12th of June, again with members of our psychology department, and our next theme will be older adult mental health. So registration for that is actually open on our website at the moment on stpatricks.ie/events. That's it from us. Thanks again, everyone. Take care.
And thanks for your time. Okay.